in looking for actual JC virus DNA, which means you've got an active infection, well, obviously healthy controls it's not there. But if you have an immune disorder, such as HIV, then a lot of those HIV patients will have active replicating JC virus within them. So if you alter the immune system, then your JC virus becomes active. And this is true of people with PML, obviously at even higher level. But also notice not 100% of PML people have the JC virus actively replicating in their blood. What is suggested is that the JC virus that is sitting in our bone marrow and our kidneys may have to undergo some change with the effects of alteration in the immune system, such that it then becomes what we call neurotropic, i.e. it likes the brain and then it travels to the brain. And this is just a rather overcomplicated diagram, which I have no idea what it means, but apparently there's a genetic change there. Okay, so when does this mutation occur? And well, there's some evidence that when we see people with PML, they have the IgG and not the IgM. So it suggests that the virus has been in the system for a long time. IgM tends to occur when you have a fresh new infection. So it suggests that the virus has undergone change over time. PML is rare in children, again suggesting you have to have the JC virus sitting around for some time before it converts into this neurotropic virus. And we've had some models now where it's some 8 months before, it's been around for at least 8 months before it actually presents with PML, the altered virus. So before HIV came along, we saw PML predominantly in people with hematological neoplastic disease, i.e. cancers, lymphoproliferative diseases such as cancer and such like. We saw it in some diseases, inflammatory disorders like sarcoid, but that's different to MS, so we didn't ever see it in MS. And other immune deficiency disorders, cancers. And really this is before HIV became commonplace. And really HIV then took over as the most common cause for PML. Then linking this up with natalizumab, well, as we heard, it was in about 2005, 2006, we were really all preparing to launch this new drug, natalizumab, which was very promising for MS treatment, but unfortunately almost at the precise point of launch, commercial launch, 2 patients were detected as having PML. And this really raised up the spectre of a downside to this promising treatment. As we've heard, natalizumab, or its commercial name Tysabri, works by blocking the adhesion molecules on the lymphocytes. By blocking those, it stops the migration of the white cells from the blood into the brain, causing damage. And that's how Tysabri works. Since the initial 2 cases, which occurred in the original study group, Tysabri has still been commercially released, and I think it's something up to 60,000 patients are now being initiated on Tysabri worldwide, and that's since about 2006. So we've got an idea now of how the incidence of Tysabri-related PML is developing. So if we look here, back here, it was felt that the incidence of PML was about 1 per 1,000. Initially, post-marketing, it went down to about 0.5 per 1,000. But as we see increasing number of infusions, getting to 24 infusions, we're seeing the figure going up to 1.28 per 1,000. We do see it drop off here, but you've got to remember that most of this 60,000 people on it are at this stage here, 12 fusions and so. So we haven't really seen the numbers fully yet, and I think we're going to have to watch and watch this space for the true incidence of PML and whether it is related to duration of exposure or not.